Good evening, everyone. I am Hebzi, representing Science Integra, and I extend a warm welcome to all of you to the 26th webinar of Maha Smile Cleft Care for Every Child. This event is organized by MOX in collaboration with Smile Train India and the Public Awareness Committee of FOXY. With the aim of raising awareness about cleft lip and palate conditions in children, it is my pleasure to introduce Dr. Leela Imam, the Program Officer of Smile Train India, who will be addressing us now. Over to you, Dr. Leela.
Good afternoon, everyone. My name is Leela. Thank you for the introduction, Hebzi. And I am for the Smile Train, and we look up. Basically, everyone knows about the Smile Train, and we provide free cleft lip and palate surgery to all the children who are born with a cleft in any part of the world. So we operate in 80 countries, and our vision is that every child who's born with a cleft lip and palate receives a high quality, comprehensive cleft care and is able to lead a full and productive life. So when we talk about the smile train, we not only doing the surgery, we are talking about, like early diagnosis, understanding why the cleft happens. Then when the child is born with a cleft, because the children who are born with a cleft have a compromised airway, they have a problem feeding, and sometimes we see the children who are born with a cleft, their nutrition is compromised, they're malnourished. And so it's very important the child who is born with a cleft, before they go for a surgery, their nutritional status is good, they are not stunted, they are not wasted. And to make sure that and to make sure that we have to give them, we provide them with the nutritional support. We have a nutrition program we're running in most of our hospitals. And then we make sure the child is healthy for a surgery. And after the child has had a surgery, like sometimes before the surgery, there is a nasal alveolar molding which is required for the dental care, so that the gap is reduced after the child is born. If they have a palate, sometimes there is a cut in the palate, so that there will be no eruption of teeth. That the children with a cleft palate, they require dental care. And we have seen a lot of children who are born with a cleft, they are prone to the middle ear infection. So, and sometimes because of the middle ear infection, they have a constant flow of pus, or it can destroy the middle part of the ear, and sometimes they can lose the hearing also. So we do provide a ENT care also to these children. And then we've seen the children who are born with a cleft, their speech is impaired. We've seen that sometimes because of the gap, the airflow, their air, comes out of their nose, and the speech is not intelligible. So we have seen these children who are born with a cleft, they have a nasality, and other people have a problem understanding what they are saying. So sometimes we've seen these children when they go to school, they are not able to make friends. The other children make fun of them, or like teachers is not able to. And so sometimes what happens, these children, they get so introvert, then they don't come out, they don't want to go to school. So we have a speech program in which we do assessment, we do counseling, and we help with the children's articulation of speech, wherever the errors are. And with through the constant speech therapies, we look into those articulation error. And then when the child grows up, they need a lot of orthodontics. Sometimes some teeth are missing because of the misalignment, because of the shortage of tissue in the palate area, so they require the orthodontic care. And then also the children, sometimes we've seen, because the anomaly is on the face. So people sometimes, children, they have a low esteem, or someone is making fun. They are very conscious of their look. So we do provide a counseling and support. So this is what we are is a Smile Trace comprehensive cleft care program. And to do this, we've been supported by the Bajaj Finser. They have been supporting us in Maharashtra, and they have been supporting our program. And the main purpose of the program and the support is that every child who's born in Maharashtra has an access to the free quality care. And for that, we have set up a helpline number, which is mentioned over here, 1-800-103-8301. So this is, a call comes directly to the Smile Train. We have helpline officers. They can help anyone who's is in distress or is in need of the cleft care. And, and so far, since January 2019, we have connected almost 9,500 calls, and we have directed them to our partner hospital. So mainly this is our initiative where we, want to provide the comprehensive cleft care. So any child you come across, and, our main purpose of our partnership is that, because you people are the first ones who come across the cleft child, because when child is in vitro, you come to know through the radiologist the child is going to be born. So you can refer it to our partner hospital. The partnership is to raise awareness about the cleft and direct them to the Smile Train partner hospital for free and a quality service, surgery. Thank you very much. Back to you, Hebzi.
Dr. Monica.
Thank you, Leela ma'am, for the update about what the Smile Train project is all about. And we at AMOX, under the chairmanship of Dr. Kiran Kurtukoti sir, the AMOX president, Dr. Bipin Pandit sir, the secretary, are very happy to partner with Smile Train, as this initiative was started with our immediate past president, Dr. Pardeshi sir. So we are thankful that we are continuing this program since the last 3 years now. This is the series 3, episode 26 of the Smile Train, and today we have an esteemed guest, Dr. Sita Ramurthy Pal ma'am, who is also the chairperson of the Genetics and Fetal Medicine Committee of FOXY, who will be speaking about the ultrasound diagnosis of cleft lip and cleft palate. To grace this webinar, we have Vice President-elect Dr. Ajay Mane sir from AMOX as our chief guest, Dr. Sujata Dalvi Madam, the editor, Jogi, and Dr. Varsha Baste Madam, VP Foxy, as guest of honor for the inauguration. May we begin with seeking blessings from Lord Almighty. Hebsi, can we have the inauguration slide? You will need to double click on the... There's no audio, Hebsi.
And the audio is playing actually.
We can't hear you.
But we can't hear. No, we can't hear.
Before sharing the video, you must click on the share sound or audio, likewise. Right lower corner.
It wasn't audible?
No, it wasn't audible.
Go back, and before sharing, you click that on right lower side.
Share audio is what you need to click.
Share audio, correct.
Share audio, there's no option to share audio.
No.
Yeah.
Below your photo on right lower corner. There is option before sharing. Click in that square, share audio.
There's no option, sir.
It's okay. See, with the blessings of Lord Ganesha and
Go ahead now.
wishing you a very happy Christmas also in advance. I would like to introduce our chief guest, Dr. Ajay Mane, sir, who has been the past president.
Monica ji, we'll skip that.
Yes, sir.
We are here
Sir,
to
over
listen.
to you for your blessings, sir.
We are here for the Sita's lecture. See, thank
Yes,
you,
sir.
Monica, thank you, Madan, Hebzi, and Leela ji for inviting me here. And I belong to the family of AMOX and Foxy, so I'm not the guest as such. But thank you very much for the honor. And the today's topic is very much interesting because it will be given by Dr. Sita, who is a renowned speaker in fetal medicine all over the world, not only in India. She is famous and she is a credible score in diagnosing the antenatal anomalies and fetal medicine problems. She is a chairperson, genetic and fetal medicine of the FOXY. And today the chairpersons are Dr. Preeti and Rajasi, who again are well-versed with the topic, and they are also expert. So they will add their knowledge to Sita ma'am's lecture. And I congratulate the conveners, Monica and Supriya and Madan. And I welcome my guest of honors, co-staff honors, Dr. Varsha ma'am and Dr. Sujata ma'am, both are senior to me. And just a suggestion from my side to Leela ji, as I'm seeing this mission going from Smile Train, I think since 25 years, I think I'm seeing through Lions community, you're serving the society all over the world. But just a suggestion to whomsoever you are operating, then follow them in their life and try to avoid in the next generation, because there are few genetic problems, few nutritional problems which are the causes of the cleft lip. So you work on that front also, so that will reduce the number of incidences. So this is my small suggestion to you. Just be on the that front also. Okay. And so I will not take much time because you are eager to learn something from Dr. Sita, and I have heard her so many times, but every time I find something new because she is that knowledgeable. So thank you very much, Monica ji, for calling me here and inviting me here as a chief guest. Thank you very much, and best luck for this webinar.
Thank you, sir. Thank you for gracing the occasion. And I would now request Dr. Madan, sir, to introduce Dr. Sujata Darve, madam.
Monica, I think you can skip that part also. I'm just telling you. Okay.
Okay, ma'am. Thank you for joining. Please
Yes.
rise your.
Okay. Thank you so much. Thank you, Monica and Madan, for skipping that part. But at an outset, I would like to thank the organizers for giving me an opportunity to be a guest of honor, for which I would like to express my gratitude to AMOG's President, Dr. Kiran Kotakoti, and convener of today's program, Dr. Monica and Dr. Supriya, and of course, Madan as the master of ceremony. I would also like to acknowledge the words of wisdom given by our second vice president, Dr. Ajay Mane. And I'm sure whatever today the speaker is going to be speaking on, that is Dr. Sita Pal. She is expert in fetal medicine, and she is going to give us a good knowledge about sonographic findings of how to make a diagnosis of cleft lip and cleft palate. This, though we call it as not a very lethal malformation, it's more or less we call it as a major malformation, because the moment child is born with this deformity, child has lots of problem, right from compromisation so far as airways and malnutrition is concerned. And whatever Miss Leela ji spoke about on Smile Train and how they are carrying out this project of correcting this cleft lip and cleft palate free of cost for all the newborns that are being born in our country. That's a great achievement. And of course, this project or this association with AMOG started during the time of Dr. Rajendra Singh Pardesi, when I was the secretary under his tenure, and this has been going on last 3 years, and I'm very happy the way it is going on, and it should go on further like this, so that it not only creates awareness among our colleagues but also creates awareness among general population, so that for in major this thing they can actually try and avoid having this anomaly. And in case it is detected, I've had couple who have come forward to me asking for termination of pregnancy, and if they are within the permissible limits, you have no other choice but to terminate. So even patients don't want to continue with a child having cleft lip and cleft palate. Now I will not come in the way between my this thing yourself and Sita, and I would like to wish today's webinar best wishes and good luck to all of y'all. And of course, I forgot to mention the chairperson, that is Dr. Preeti and Dr. Rajasi, and wishing you best luck for their future endeavor in Foxy. Thank you so much.
Thank you,
Thank you so
Sujata,
much.
ma'am.
Thank you.
It
Thank
was
you so much, ma'am.
Thank you.
It was the groundwork, ma'am, that you had laid down, and we are continuing with the last 3 years. This basically aims to only sensitize all the obstetricians and gynecologists across Maharashtra, so that at least we prevent the MTPs and we can counsel them in a better way, so that these babies see the light of the day and they have been managed right from birth to at least 1.5 to 2 years till they start getting operated for multiple procedures. And that is the work that Smile Train is doing. Thank you so much,
Yeah,
ma'am.
but Monica, because of sonography, they're able to make a diagnosis, and couple are coming to us for termination. That much awareness has been created all over. They don't even want a child to be born with such a deformity, not because for themselves, but because child should not be suffering because of the deformity. So that is basically a big awakening so far as the general population is concerned.
Thank you, ma'am. Thank you. I would now request Dr. Varsha Baste, madam, our next guest of honor, which is the current Vice President, Foxy. Madam is Director at Baste Maternity Hospital and Pushpa Fertility Center. She has
Yeah,
been the
thank you.
yes, ma'am. She
Thank
has
you
been
so
the
much.
chairperson. Ma'am, the dais is all yours for your
Okay.
blessing.
Yeah. Thank you, Monica darling, for inviting me and making me the guest of honor along with such a stalwart Dr. Sujata Dalvi, madam. I really like the idea of smile train. It is a must in nowadays because of the cleft lip problem and all what you are just discussed just now. And it is such a important issue. We do not feel the implication of it, but the patients are really sensitive and they do not like फटे उठ वाला बच्चा ये abnormal है क्या कुछ कर्स है क्या they have many fastidious what you say apprehensions and queries also. So this smile train definitely is a good bridge amongst the doctors and patient to detect it and how to prevent it and how to tackle it. So you are wonderfully doing, and by joining this smile train, even we had arranged these same sessions at my conference recently of as vice president. I had my conference at Nasik OBGYN Society, and especially we had invited surgeons and who are operating for the cleft lip palate to the pediatric surgeons, and all were involved and they discussed, and it was really well received in the conference. The audience was really spellbound. I really thank you for making me the guest of honor. And I can see my friend Dr. Ajay Mane sir, Rajasi Sen Gupta, Madan Kamble, wish you all the best. And Preeti Vyas, she is also doing so much of work and very active Foxian. I wish her all the best. And who other than Dr. Sita Ramamurthy Pal, who is giving the talk on this. She is a stalwart in fetal medicine and she will be giving definitely justice to this topic. So I wish you all the best and please carry on. Thank you.
Thank you, Varsha ma'am, for gracing the occasion. And the VP Con was very, very well received. Congratulations on being the organizing chairperson. I'm sorry, ma'am, I couldn't be there due to a
It's
family
okay, it's
commitments.
okay. Even Ajay couldn't attend, Rajasi couldn't attend, but it's okay.
Thank you, ma'am. Thank you so much. I thank Dr. Ajay Mane sir, Dr. Sujata madam, and Dr. Varsha Basse madam for gracing the inauguration. And I declare that
Thank
the
you.
inauguration is over.
All
Over
the
to you,
best,
Madan
dear
sir.
Monica.
Thank you. Thank you, ma'am.
Nice
I now
Dalvi, madam.
request Dr. Madan Kamble sir to please introduce our chairpersons for today.
Yeah, Madan, can I speak one sentence?
Yes, sir, please.
Yeah, thank you. Thank you very much. I forgot to wish all the best to Dr. Preeti for her endeavor in the Foxy. We all are with you, Preeti.
Thank you. Thank you. Thank you so much, Dr. Mane.
Yeah, I'm so
Sir,
sorry.
Rajasi also and Madan also, sir.
Yeah, Rajasi, obviously. Sorry.
Yes, thank you so much, sir. Thank you.
Both are
Varsha ma'am,
All the
also
best,
thank you.
all.
Thank you,
Most
sir.
All
welcome.
the best,
Thank you,
all the
Varsha
budding
ma'am.
And I
Foxians.
appreciate the work of Monica and
Supriya.
Supriya. They both are chairperson elect. Their tenure has not been started yet, but they have started working. So
I
appreciation for
know.
both, and best luck for Rajeshri and Preeti.
Thank you, sir. Thank you so much.
Thank you so much. Thank you so much.
Thank you.
Yes. Yeah, next slide. Next CV slide of chairpersons.
I think, Dr. Madan, we should start the program. You don't really need to introduce.
Yeah. Okay. I welcome
Fit
Dr.
with
Preeti
me.
Vyas as a chairperson from Mumbai. She is active Foxian. Yes. Next, Dr. Rajshi Sen Gupta, who is the past secretary of Nagpur OBGYN Society. She is professor at Medical College, Nagpur. I welcome Dr. Rajshi Sen Gupta. I request Dr. Rajshi to introduce Dr. Sita ma'am, speaker. Over to you, Dr. Raj.
Thank you so much, Madan sir. Can I please have ma'am's CV? Actually, it is an honor and privilege to introduce a person of such a huge CV
शी इज सो हम्बल एंड मॉडेस्ट दैट मैडम ने इतना छोटा सीवी बना के रखा है, बट हर सीवी एक्सटेंड्स अ रियली लॉन्ग वन. So we welcome our guest faculty for today, Dr. Sita Ramamurthy Pal, soon to be the First Lady of Foxy. She is a consultant fetal medicine and obstetrician at Apollo Multispeciality Hospital and Institute of Fetal Medicine in Kolkata. Madam has been an honorary joint secretary of the Bengal OBGY Society in 2024-25. She is the chairperson of the Genetics and Fetal Medicine Committee of Foxy at present for till 26. She is also president of the Kolkata chapter of Society of Fetal Medicine, a fellow representative of RCOG IRC India East. She is a joint secretary of ISOPAR Kolkata chapter, an examiner at MRCOG Part 3 and a faculty of MRCOG both Part 2 and 3 courses. She is a member of National Board of Specialist Committee of Maternal and Fetal Medicine, a peer reviewer of our own Jogi and Journal of Fetal Medicine, and a faculty trainer of Foxy recognized training centers. Apart from this, Madam is an extremely well-known academician of international repute, and we have heard her on so many platforms. It's always a pleasure to listen to her because the way she speaks, most complicated topics she puts forth and teaches us in a very lucid manner. So, welcome you, ma'am, and over to you. Thank you so much. Hello, Sita ma'am.
And I'm having a bit of an issue with my network for some reason. But thank you all for the kind introduction and Dr. Ajay Mane sir, Dr. Sujata Dalvi madam, and um, Dr. Monica for initiating this. Can you hear me?
Yes, ma'am.
Yeah, and Dr. Madan Kamble and Dr. Preeti for being the chairpersons. I mean, it's amazing what Smile Train is doing. So congratulations, Dr. Leela, for the effort and for all the contribution that Smile Train is doing for the welfare of these kids. But I think it's important that we recognize them antenatally and give them the proper direction and counseling so that, as Dr. Dalvi madam said, most of them do end up in termination, which is not the right way because it is one of the best correctable anomalies that we have in. So I'm just sharing my screen. Can you just hang on? Yeah. Can you see?
Yes, ma'am.
Okay. Yeah. So good afternoon, everyone, and thank you once again.
Hello. Maybe doctor is facing some network issues.
Yeah, I'll just call her. Wait.
Okay.
She's just trying to join back in a minute's time.
Okay, ma'am.
I think in the meanwhile, I'd like to just mention that I think this project that you have taken up, Monica, I think it's a fantastic initiative, and I think kudos to you because you have been consistently, continuously doing this project. I mean, for Amox for the last 3 years, and it takes a lot of commitment and a lot of leadership qualities to continue doing this project. And I know how busy your schedules are. And in spite of that, Monica has always been the go-to person. You need any help, you have to call up Monica. She'll be the one person who'll know everything. Okay, great. I think Dr. Sita has managed to join. And I think Leela ma'am, what you people are doing, I think it's really commendable because to be able to continuously do this, and to continuously keep supporting the individuals is really not a joke. I mean, it's amazing work. Welcome, Dr. Sita.
Thank you. Thank you. I'm sorry. Actually, I was at a place where the network was very good, but unfortunately, there was some work going on in the background and there was too much noise. So I had to move, and then the network was bad there. So, anyway, right. Thank you so much, and thank you for being patient. So, we're going to be talking about, am I audible and visible now?
Yes, ma'am.
Yes,
Yes, ma'am.
Thank you so much. Right. So we are going to be talking about the antenatal approach and the ultrasound features to fetuses with cleft lip and palate. And that's me for you. And thank you once again for this opportunity. So cleft lip or with or without palate can happen. And that's one of the most common congenital birth defects. And the prevalence varies from around 1 in 500 to 1 in 2,500 live births. It's almost as, prevalent as Down syndrome. But the problem is that we counsel so much and we concentrate so much on Down syndrome. And these are things that can be picked up antenatally, and if isolated, they have a brilliant prognosis. Of course, the prevalence varies by race and it's more frequent among Asians. It doesn't have, if it's isolated, there is not much of a problem, but it can be associated, as we heard, with a bit of morbidity for the neonate, especially in the early childhood, be it physically drinking and feeding issues, as well as cosmetic issues, because they need to wait for some time until the repair is completely done. Very important to note is that if it's part of a spectrum of anomalies, when there are other associated anomalies, then it can be a marker of genetic syndrome. And as I said, there's been a major impact of technology in diagnosing and prognosticating these conditions, and that is why we are here to talk about it, so that we can make everyone aware. Because a lot of time when we counsel as fetal medicine specialists, they go back to their obstetrician and go back to the social, to their society outside, where they say this cannot be, it's incompatible, you have to terminate it. Now, in the context of facial clefting, it is obviously cleft lip may describe the upper lip only, or the upper lip and the alveolar ridge, as well as the alveolus. And overall incidence, as I said, of the cleft lip and palate malformations is in the range of 1 in 700. And it is similar to that of Down syndrome and talipes. When you talk about isolated cleft lip, which can be either a lone cleft lip or with the alveolar ridge, it is around the range of 25%. But if usually cleft lip is associated with cleft palate, and they can be of varying degrees, as we will see, and that is in the range of 35%. Of course, 25% can be unilateral and 10% is bilateral. The most common is cleft lip and alveolar ridge, which is easy to diagnose. But isolated cleft palate is unfortunately quite uncommon, but at the same time difficult to diagnose as well. Now, the critical period for cleft development starts from the 4th week and it goes on. It finishes by the end of 10th week, but the ossifications can continue up to 12th week. So by the time we have this fetus coming in for the first trimester scan, which is also now a basic morphology scan of the fetus in the first trimester, we should be able to pick up signs which may tell you that there is some problem lying here, or trying to tell us something, there is an issue, so that we can accordingly screen them or maybe get them earlier. So the primary palate is formed by the 4th and to the 7th week, and we will see how the secondary palate is formed by the 8th to the 12th week. So initially, when the nasal placode is formed and there's a rudimentary membrane which divides to form the mouth, you have basically the frontonasal prominence. Then you have the median nasal processes, the natural nasal processes. You have the maxillary prominence and the mandibular prominence, and this is what happens in the early 6th week. By the early 7th week, why 1 week after this, the median nasal processes actually start fusing, and then the rest of the mandibular prominences, the maxillary prominences start moving inwards, and by the 10th week, the entire spectrum of the philtrum, the nose and the lips and the lower lip, and as I said, the ossification continues off up until the 12th week. So it is basically the fusion of these 3 prominences which is very critical in the development of the cleft lip, palate, and the lower lip as well. So any insult in this period of gestation, be it any anti-epileptic drugs or any other drugs which can cause an insult in this process of development of the lip and the palate, will cause a clefting and will depend on when the insult is and what type of insult is. So if you see, the frontonasal processes actually develops into the forehead and the dorsum of the nose, and when they fuse, the lateral nasal processes actually forms the lateral aspect of the nose, and then the medial nasal process forms the septum of the nose and the philtrum, if you can see here. And then the maxillary processes, when they fuse, they form the upper cheek, most of the upper lip is formed, and the secondary palate. And the mandibular processes, which lower down, forms the lower cheek, chin, and the upper lip. Okay, so by the end of the 10th week, we will have this sort of a picture, which all of these placodes and the pharyngeal arches, which are actually contributing from the beginning, they're all coming into the center, fusing. So any midline fusion defect will result in clefting. Now, when we talk about, that was the lip and the primary palate, but when we talk about the palate properly, initially what happens is the nasal cavity is continuous with the oral cavity. And as the nose and the placodes and all form, the fusion, as I said earlier, of the medial nasal prominence, along with its contralateral part, it forms the intermaxillary segment, and this is actually the primary palate. And in the meantime, the maxillary prominences, which are in the side bite, they also start forming, and they expand medially to form what is called as the palatal shells. Now here what happens, the tongue is also forming, and then the tongue falls back, and then the palatal shells actually fuse with each other in the horizontal plane and the nasal septum in the vertical plane, and they all form the secondary palate. So this is, this happens at the same time, but here the defect will involve the primary or the secondary palate, and that is what we need to see when we're assessing the lip and the palate in together. So when we talk about assessing the cleft, assessing the lips and the palate, basically ISOWOG, which is our Bible for antenatal ultrasound, it has given us clear-cut guidelines as to how do we assess this in the second trimester, and now it has, we have expanded this to include it in the first trimester as well. And we have a typical 20+2 plane approach, where the plane 18, 19, 20 actually concentrates on the lip orbits and the median facial profile. This is ISOWOG mainly concentrates on the lip. They say it's mandatory, but they don't say the assessment of the palate is actually important, or rather necessary. I won't say important, it's not necessary. But having said that, we'll see that when you are having a cleft lip, it is actually incomplete, because the next question that comes is whether there is an associated cleft palate or not. So when we look at the 20+2 approach, the plane for the different plates starts with the spine, and in the head, 3 planes of the head, where the 4th plane is the transventricular plane, and then you rotate the probe and slide it around 45 to 70 degrees when you come to plane 18, which is the coronal view of the upper lip, nose, and nostril. Plane 19 is both the orbits, and the plane 20 is the median facial profile, which we'll come to. Again, we sort of rotate the movements and slightly angulate it through 90 degrees. So again, all starting from plane 4, you go back to your plane 4, and then you come, rotate, and start looking at plane 18, 19, and 20. So this is the coronal view, which is also known as the nose-chin view. And this is tangential to the nose, lips, and chin, basically. It's the coronal view. And this is a very important picture in the anomaly scan. And this has to be taken and you have to have a report or image of it, which tells you that you've actually looked at it. So this is typically where you look at the nasal nostrils, the upper lip and the lower lip. And exactly when you have a fluid in the oral cavity, that sort of delineates the upper lip and the lower lip so beautifully that you can see if there are any defects. And it is important that the entire, this segment of the nose-chin view should have liquor clearly around it, and it should not be stuck to any part of the fetal, of the placenta, or it should not have any cord or any hand coming in front of it, which will obscure small defects. So what we look as the intact nasal tip, the 2 symmetrical nostrils, the upper lip and the lower lip and the chin, and this intact upper lip actually rules out a cleft lip. Now, as I said, the ISOA guideline says there's a minimum evaluation of the fetal face, which should include an attempt to visualize the upper lip for possible cleft anomaly. So this is the plane 18, which is the upper lip, that is the nose-chin view. The plane 20, which is the fetal facial profile. Now here, basically, as I will talk to about, if you have a median cleft lip or a bilateral cleft lip, you will have a maxillary protrusion, which we will see. But there are other signs which can also tell you whether we are dealing with an associated cleft palate as well. So this is a typical facial profile view, which we take it in the 2nd trimester. And then if you go to plane 19, you can look at the orbits and also decide, because most of these cleft lips are also associated with facial abnormalities and may have other problems in the orbit like hypotelorism or hypothyroidism. So this entire spectrum is taken in these 3 planes, and we assess them as plane 18, 19, and 20. And of course, 3D is always there. So even if you do it in the 1st trimester, 2nd trimester, and there is always now, as we said, we have expanded even a growth scan is an anatomy scan. So even in the 3rd trimester, it's mandatory, or it's rather a good practice to have a look at the face, at the lips, the heart, and general, make sure that all these anatomies are good and properly assessed. So when we talk about cleft, it is basically, as I said, it can be unilateral, bilateral, right or left. It depends on the type of defect, whether it is cleft lip or associated alveolar ridge defect or cleft palate. The extent of the defect, which is very important, because the pediatric surgeon, the counseling, everything depends on that. And the width of the defect as to how long, how many procedures this baby will need postnatally, the integrity of the maxilla and the alveolar ridge, the symmetry of the nasal orifices, because these are all signs that we can identify what sort of a clefting this is, and a pre-maxillary protrusion, which happens secondary to the bilateral cleft lips. So as I said, when there is a cleft lip, it occurs when when the medial nasal prominence and the maxillary prominence, if you remember the first picture, it fails to fuse, and it can be unilateral or bilateral. And when it extends into the alveolar ridge, this is the alveolar ridge, then it will be called as the cleft lip involving the alveolar ridge. But when the palatal shells, as I said earlier, fail to fuse in the midline, then you will have a unilateral or bilateral, depending on where it is. It will be a cleft lip associated with cleft palate, and depending on how far it is involved down into the secondary palate, it could be either cleft of the lip, primary and secondary palate. So when you are reporting as well, it should identify and tell exactly what is the dimensions, where unilateral, bilateral, and how far it is involved and how far it has gone down to the palate, hard palate or soft palate. So as I said, the cleft of the secondary palate is basically the failure of the fusion of the palatine shells, and this is the primary palate. And so if you can't, if they don't fuse, you have the cleft in the secondary palate. So if you can see the nasal septum, it means that there is an indication that there's a cleft in the secondary palate, right? And typically down below is the uvula, which is part of the secondary palate. So we classically have this Kern-Hans classification. I think all those who do antenatal ultrasounds are very familiar with this, and it is very easily depicted as to what sort of clefting. So it is easy for us to diagnose, and we all speak the same language. So when the report goes to somebody else, we know that this is what is involved. And it says like 1 is the right lip, 2 is the right alveolus, 3 right premaxilla, 4 is the left. So depending on what is involved, we shade those portions. And if it's bilateral, cleft lip and palate, the entire, all the things will be shaded, and you will know this is a major defect. So a very important point to remember is when we talk about cleft lip and palate, the clefting of the lip actually starts from the lip anteriorly and proceeds in the dorsal direction and to different extents depending on whether it is involving the alveolar, the primary palate, or the hard palate or the soft palate. But isolated cleft palate actually starts from the back, from dorsal below. So it starts at the uvula and proceeds along the midline in the anterior direction. So that is a very critical point to know, because then, when assessing the cleft palates when they're isolated, it is important to remember that it starts in the uvula. So having seen those structures, we are more or less reassured that even if there may be a doubt, if there is the uvula is normal, then the secondary palate is not involved. Now, this lady is basically, she came, in fact, last week. If you remember, this lady had a high intermediate risk on combined FTS, and they did an NIPT. But when we did the scan for this at 16 weeks, she clearly had a unilateral cleft lip, and it was involving the alveolar ridge. As you can see, there is a defect here, and it is going down into the alveolar ridge. And the same thing here is, and we can see the premaxillary triangle is defective here, and it goes down from the lip into the alveolar ridge and going down into the palate. So typically in unilateral cleft lip, if you remember that nose-chin view, it has that there is a lateralized defect that partitions the soft tissue of the upper lip into 2 parts. You have a clear upper lip normally, but if there is a unilateral cleft lip, the soft tissue of the upper lip is divided into 2 parts. There is asymmetry of the nostrils. We have seen that in the normal picture, we have seen that there are 2 nostrils equal, but here there is asymmetry of the nostrils, and it looks as if the nose is actually on the side because of the ridge being pulled down, the alanezi being pulled down. You feel that the nose is actually falling down on that side, and that is typically known as the falling down nose sign. Now here, sometimes a unilateral cleft can be just involving the upper lip, or it can go towards the midline and sometimes involve the philtrum as well. Now, this is again the same patient. Here you can see the defect in the lip, and it is going down to the alveolar ridge and going right down into the primary palate as well. And this is the sagittal view, which shows that there is a defect there is a gap in the palatine process of the maxilla, and there is a defect there. So this is the defect in the upper lip of the cleft lip unilateral, where it measures about 3.2 millimeter. And obviously, in these sort of conditions, when we take a 3D view and show them to the couple, they sort of can actually understand what the defect is and what happens. And luckily for this lady, she didn't have any other associated anomalies, but we have done, as you can see, I was just diagnosed on the 15th. So we have sent her amnio for genetic testing, because she's already for chromosomal microarray, because already the double marker or the combined FTS was showing an intermediate risk. Now, as I said earlier, sometimes the cleft lip unilaterally can involve the philtrum, and this is another patient in the anomalies can be diagnosed, where it went up into the philtrum. So it was a clefting, it involves the philtrum. So it looks like a median cleft palate, but it is actually unilateral involving the philtrum. And so that also so sometimes these are called as a mediolateral cleft lip, which involves the alveolar ridge as well. Again, the same thing, which going down into the alveolar ridge, but here the secondary palate was not involved. In bilateral cleft lip, there is premaxillary protrusion, because what happens is here the nose is, the upper lip is divided into 3 portions. There's a defect in the middle, on each side, and the premaxillary protrusion occurs here. So there is echogenic soft tissue mucosa under the nostrils, which is actually the median process. And this median process appears as the premaxillary protrusion. So here you have the same patient with bilateral cleft, and you can see the premaxillary protrusion right in the center, which is the median process, and also showing the 2 bilateral cleft lips on each side. Now, even if it is unilateral or bilateral, even there are no associated anomalies, even if the combined risk is low, we would definitely recommend a genetic testing, because you never know, this can be involved. And to say that this baby is otherwise apparently normal, you need to prove it genetically that this is normal. So you cannot assume that everything is normal just because we can't see any other anomalies. So as a practice, we routinely tend to recommend, but it's important for them to understand, and then they have to make the choice finally, right? So this is the same patient where she had a bilateral cleft. The baby was not in a good position, but we could demonstrate this patient actually decided to terminate, and she went ahead and terminated the pregnancy without doing any testing. But the other 2 patients have actually continued, and we are still waiting for the results. Now, it is a very crucial thing to differentiate between bilateral versus median cleft lip is as I said, as we saw earlier, in bilateral cleft lip, there is a presence of the maxillary protrusion, whereas in median cleft, there is an absence of the median process. So you will not have any premaxilla, and there will be no maxillary protrusion. Now, what we heard so far is about the cleft lip, but needless to say, assessment of the cleft lip is incomplete without cleft palate, because if the family has had a previous child with cleft lip or palate, or if a parent is affected either with one of them, or there are associated genetic syndromes, the couple obviously wants to know what is the future for this for my pregnancy, and whether recurrence risk is there. And as we have we always want to mitigate recurrence, and that is why it is important to assess the entire thing in total, whether the cleft lip is associated with cleft palate or not. Now, when you talk about evaluation of clefts, it is a bit difficult, because it is a bony thing, and it's a dome-shaped structure. So with the 2D at different planes, it may be in a single plane, it may be difficult to assess where exactly the cleft is and what part of the cavity of the cleft, primary or secondary, is involved. So there are different things that we look at and make sure that the clefting of the palate we suspect, and then we need to confirm it with other sections, either by 2D or 3D. So fluid in the oral cavity and avoiding shadow from the tongue and facial bones is very important to evaluate the extent of the cleft. And that is why we say that, because the clefting of the palate starts from the uvula, if you see an unremarkable uvula, we know that the secondary palate is intact. And even if you tend to sort of see, or sort of a false positive, once you see an unremarkable uvula, you are more or less reassured that this is a normal secondary palate. And of course, 3D ultrasound techniques have improved the detection of all these, and they provide confirmation along with the 2D markers. Why do we say this? Because clefting is associated with chromosomal abnormalities, especially if it is a median cleft. It is a holoprosencephaly with proboscis. There is bilateral cleft lip and palate. There can be 15 to 30% association. Even with unilateral cleft lip, there is 5 to 15% association. Isolated cleft lip, of course, it is a low association, but as I said, how do we prove it's isolated? We have to prove it genetically that everything is normal. So it is a good practice to recommend genetic testing. And cleft lip palate can be associated with those common trisomies like trisomy 18 and 13, but these have usually other barn door ultrasound features which we cannot usually miss. And of course, maybe your combined markers will be also high. So the typical syndromes that are associated, it can have any of more than 400 syndromes, can be golden hour syndrome, where there's anophthalmia, there is macrosomia, there are ear defects, Treacher Collins and Pierre Robins, where the entire facial profile is abnormal. They have micrognathia, retrognathia. and they occur due to either de novo or autosomal recessive mutations. It's important to test the fetus and test the parents to see whether they can recur again, or it can be a part of a Pierre-Robin sequence where they have cleft palate and glossoptosis, and these have to be typically diagnosed antenatally, because if it's not, then at birth they can have severe problems with airway and breathing. So we have as I said earlier, we did have the guidelines for the second trimester, and now we have extrapolated them to using them in the first trimester. So even in the first trimester, we have a checklist of looking at the face and the lips and the maxilla. So these are other structures that have to be seen, that is the face and neck, bilateral orbits, nasal bone, maxilla, retronasal triangle, upper lip, mandible, the nuchal translucency thickness, which we typically look in this image, and we have all the other features that we see. So here we can suspect if there is a problem, because in this typical image, besides the nuchal translucency, besides looking at the nasal bone, this is the maxillary second palatine process of the maxilla. And if there is a gap in this process, if there is, what is the gap is known as the maxillary gap, then we suspect that there is a palatal abnormality. Also, a beautiful sign described by one of our very own, that is Dr. Lakshmi Ravi from Chennai, from Tamil Nadu. She has described the superimposed line sign, which also typically looks for these isolated or cleft associated cleft palates, which are typically seen between 12 to 20 weeks of gestation. So this is a maxillary gap sign, which is a marker of cleft lip and palate, where we have the maxilla here in our typical view. And if the gap is more than 1.5 millimeter, it is significant enough to be called a palatal cleft in the palate. And of course, this needs reconfirmation in axial planes of the maxilla or in the retronasal triangle view, which we go to, and the absent superimposed line sign, which is seen typically between 12 and 20 weeks, where the voma appears. Now, if you look at, so when you look at the maxilla, and this is, from 12 weeks, you can see that is the palatine process of the maxilla and the vomer bone, and the nasal septum actually fuses. So if you have this superimposed line sign where it is the premaxilla, the secondary palate, and the vomer bone, if you see all of them together, then you know that the palate is intact and there is no suspicion of clefting in the palate. So this is the maxillary gaps line, and in the absent superimposed line sign, which is typically seen in the 12 to 20 weeks. But of course, in the later mid-trimester, this can be difficult to see. So we need other signs to make sure that the clefting of the palate is not involved. So in midline cleft of the secondary palate, the maxillary palatal line is absent. So you have only the single one, only the vomal bone is seen, and this has a sensitivity of almost 90% in detecting cleft of the secondary palate. Right. So this is one which is courtesy to my friend Dr. Shankar from Asansol. He has shown we have a typical clefting in the first trimester where you can see the maxillary gap sign, and this image shows there is in the coronal view where we are looking at the clefting of the lip and the palate. And this is the 3D picture which showing the clefting of the palate. So the intact process, the premaxillary triangle is absent, and you can see the clefting of the lip. So as I said, we look at this premaxillary triangle either in the first trimester or in the second trimester. And this is a very, very crucial, very important landmark, because this triangle tells you exactly, even if the soft tissues may not be visible in the first trimester or early second trimester, these bony landmarks are seen very, very clearly. And there, the frontal process of we have the two nasal bones forming the tip of the triangle, the frontal process of the maxilla, and the primary palate. So if this retronasal triangle or the premaxillary triangle is intact, we are sure there is no clefting of the palate. So the same thing can be seen in the second trimester as well. Along with the Neustrian view, we have the premaxillary triangle even in the first trimester, and you have other views and the orbits, as I said. So this one thing, along with the sagittal view, which tells you about the so every plane that we assess in the first trimester and second trimester can give you clues about whether there is an associated cleft palate or not. So in the first trimester, we have the maxillary gap sign and the retronasal triangle. In the second trimester, also up until early second trimester, we have the superimposed line sign and the retronasal triangle along with the nose-chin view. So as I said, this is the continuous palatal line that we look at, and if you see the overlapping of the two bones along the vomer and the palatine process of the maxilla, you know there is no involvement of the clefting in the palate. Again, here you can appreciate that there is the normal overlapping of the two bones. So you have this superimposed line sign, which is basically formed by the fusion of the primary and secondary palate, and then the secondary palate merges with the vomer in the midline. So there are other views we have put in, and now that has come into play, where we look to see whether the clefting is involved the alveolar. So this is the arch view where you're looking at the alveolar ridges, and this is basically an axial view which goes through the maxilla. So in normal upper jaw, there is an underripted curvilinear row of tooth buds. You can actually see the tooth buds, and if you see tangentially going through the aerial view of the mouth, you can see this entire process of the maxilla of the alveolar ridge along with the mandible. And if there is any clefting, you will know that there is a gap here, and that would tell you whether there is a clefting of the primary palate. Now, sometimes, as there's also been a sign of looking at the posterior edge of the palate, because the posterior edge of the palate is much far behind, and it's the premaxilla actually forms a shadow on top of it. So sometimes you can't really see it very well. So these signs have been explained now in 2020 by this group 4 et al., where they look. What happens is, as I'm telling, if you look at a sagittal view as you form the primary palate and the secondary palate, this premaxilla actually casts a very dense shadow. So you can't see this part of the hard palate and the soft palate unless the baby is in complete extension. And you look at the complete secondary palate along with the uvula, which is also called as the equal to sign. But for this, you have to really wait for the baby to extend its neck, have some fluid in the oral cavity, and that is why we look at other features of the uvula of the secondary palate. And this is why it becomes difficult to diagnose this later in the second trimester. So if you have early first trimester, late first trimester, early second trimester signs like the absent superimposed line sign, or there is a maxillary gap, or in the retronasal triangle there is a gap, you can suspect and confirm it later. So typically here again, you can't see the secondary palate very well because of the overshadowing. So now we have looked at, this is the new, where they have described as the posterior, bony posterior edge of the palate, where we go behind the same areolar ridge view. We see the transverse process of the posterior edge of the palate, secondary palate, with the pterygoid process and in the sides. So if this line is horizontal, we are more or less sure that there is no involvement of the secondary palate. So typically, this is what you would see, where this is the alveolar ridge. You go down posteriorly and you see the entire, horizontal, with the tongue interposing in between. And for this, you don't need so much of fluid in the oral cavity. So if you are in the right section, if the ultrasound rays are coming directly down below, then you are able to see this bony posterior edge of the palate. And as I said earlier, as cleft palate always starts at the uvula, the presence of an unremarkable uvula, also known as the equal to sign, it tells you that this uvula is fine. So there is a very less chance, or absolutely very, very minimal chance, that the secondary palate is involved. So of course, 3D can, as I said, can appreciate these images. So this is an algorithm which I've come to, which we can say that if there is a cleft, if it's midline, if it's involving the upper lip or the cleft of the alveolar ridge, and it goes down to the palate, primary or secondary palate, and depending on what it is, we need to counsel them accordingly. A very important aspect is to talk to the obstetrician, be in the loop, and make it a multidisciplinary approach, because you have to involve the pediatric surgeons here, and once they show them their success pictures, their success stories as to how these kids have been treated, I think they will, go forward and continue the pregnancy. So it is important to take a detailed history, what the patient might have had, have a detailed scan to search for additional anomalies, because that might not be the only one there. You might have associated anomalies. Whatever it is, offer invasive testing for karyotyping and chromosomal microarray, prenatal consultation with pediatric surgeon. And the recurrence is important because if it's isolated, the recurrence is around 5% if one sibling or parent is affected, 10% if two siblings are affected. And of course, if it is a syndromic, then it will be depend on the type of the syndrome and what forms of inheritance it has, whether it is autosomal recessive or autosomal dominant. So as I said, this is a multidisciplinary team, and this is what they do. The technicians, the obstetricians, the fetal medicine specialists, and the plastic surgeons who are involved, and especially Smile Train can, in this aspect, is provide getting us all together and providing these children a positive future, a bright future, so that these defects can be controlled, can be diagnosed. The way they need to take it forward is the adequate support and care is given to these families, and follow-up is done. So thank you so much for your patient hearing. Thank you.
Requesting
Geeta, I
Rajyasree.
think, yeah, I'm here. I think it was a fantastic this thing. I mean, literally glued to it, and what amazing images. And maybe you need to have these images compiled and put up on the Foxy website, because I think it was a fantastic this thing. I mean, it is something to be referred to, when you are trying to really learn. And so I have one question, Dr. Sita. I mean, now with the fetal medicine, this thing, I mean, people are able to pick up much earlier. But I know in the olden days, we could land up picking up cleft palate much. So in these kind of scenarios, when it has been picked up beyond 20 weeks, and then yes, we will need to do the genetic testing and everything, the reports of which would take a little longer time.
Yeah.
How do we counsel our patients on that? Because the anxiety, of course, builds up, and it becomes quite challenging to this thing. So if it is like a syndromic thing where there are multiple defects, then it's of course easier. But when it is just an isolated cleft lip, cleft palate, we want to encourage them to continue the pregnancy.
So typically, as you rightly said, that if you're diagnosing it in the first trimester, there are certain anomalies, you need to counsel. It takes time for them to digest the fact that yes, my baby has a problem. Then they go back, and then you do the invasive. Then the testing also takes time. It's not just going to happen in 1 week or so.
Right.
If you're doing a chromosomal microarray, it's going to take 2 to 3 weeks time, and then they decide. So that is why the advances are happening, so that we diagnose them by 16 weeks, so they have enough time. And luckily for us, the limit of termination is gone 24 weeks, so we sort of know we have that much time. But even if it is diagnosed in the second or third trimester, anywhere, whenever you diagnose it, it is mandatory that we do a check from head to toe and look at the baby in detail. And if the combined risk was low, if there are no other risk factors, then yes, it is as I said, it is a practice. It is good practice to recommend. But depending on the trimester, if it is late second trimester or third trimester, and if you're sure it is just an isolated cleft, or even if the palate is involved, if you involve the pediatric surgeons, I think that there is no harm in continuing that pregnancy and reassuring them that every possible support will be given to them to treat this anomaly. I would request Dr. Leela to give her inputs as well here, if if you have.
Yeah, like you rightly said, a lot of the children who are going to be born with the cleft, and then we do tell them, so there is a lot of research going on, taking to Dr. what Dr. Mane said, how it can be prevented. And when even the children, parents who are born with the cleft, and they are come to our hospital saying, how because they are worried that they will be having kids who are born with the cleft. So our surgeon does tell them to go through some tests and, take them some iron supplements and to be careful and all that, and to have the regular scanning done. So we do that, and there is a lot of research going. We are funding a lot of research also in this. But then, it is again, we have our limitations over there. And when we tell them, so we cannot advise anyone what to do, what not to do when someone is expecting a child with a cleft. It is finally the decision of the family. But we do send them to our hospitals, and where they said that if the child is born with a cleft, and how Smile Train can support and help them when the child is born.
Yeah. And these support, we also connect them with families who've had children who've had
Yes, we do.
surgery.
So,
Yeah.
sometimes, because when the mother is expecting a child, she feels, her world is shattered. She
Yeah.
doesn't know what is happening, and she's never seen a child with a cleft.
Yeah.
Like I myself, till I joined Smile Train, I did not know what the children with the cleft was. They looked like, And when I saw them, I said, yeah, I do remember seeing them. So when they see their other children, when they realize they're not alone, the other people also have this, and how the other children have overcome, how the families have navigated these issues and all that. So they do get confident, and they know, they'll be able to solve it, and they are at peace with it, and they said, okay, it can be solved, it will be taken care of. So that is something in vitro. When the child comes in, there is a lot of counseling involved. Or they go to a hospital, they make them meet the families, and then they see the children, how they were before the surgery, how they are after the surgery also, So that happens regularly, And we get more and more as we are talking, the awareness is increasing. More and more the children, we get calls on a helpline where the parents are expecting, the young mother is expecting a child, and she's saying she's going to have a child with a cleft. What can I do? What do you advise? So we do send them to our surgeons and all that.
True. And as I said, it's important that we all speak the same language, because
Exactly.
whatever we are saying, it has to be reinforced and positively said by the same obstetrician and and the pediatric surgeon, of course. So all of the geneticists, all of them involved. And that is why the general gynecologists also need to be very, very positive and strong about it.
Absolutely.
That needs to be continued, and it's not anomaly that's incompatible with life.
Yeah, it is. But then, let's face it, like when the cleft is very, very severe, it's very easy for us to sit on this side of the fence saying, so that is a call, something that the gynecologist and radiologist, they do take a call, because I remember speaking to one of the mother. She said this cleft is very severe. It's running throughout the body. And she said, what do you suggest? I said, no, I cannot suggest, it is a gynecologist, radiologist, their call. And, the people who are involved, your genetics is involved, how bad, severe the cleft is. And then she said, was in the first trimester.
Right.
Sometimes in the first time, you can't make out the severity of the cleft also until, the child is fully grown,
Yeah.
So these are very double-edged shows.
And then when they sometimes meet the pediatric surgeons, if depending on how socially the couple are, because of the number of surgeries are involved, the care that's involved.
Exactly. So there is a burden of
all
care
that they
also.
have to take. That we cannot decide for them, but at the same time, we can't be God as well. We can't play God and say that, So it's totally a decision that needs to be taken by the family, and completely we can't put ourselves in their shoes, or they can't make us.
Yeah, that's what I said. No, we can suggest, we can advise. The ultimate call is that we can tell them that the child is born, this is what we can do, And because we've seen, like most of the children who are born with a cleft, the mothers are so negligent because the life is so cheap, because they think they can have a second child, they let the child go.
That is true.
Because it's first time mother, because she's facing so many taboos. The only thing, like we try, like recently in our hospital, the mother completely ignored. They gave her the nasal pharyngeal airway they gave. The mother did not come back for 2 months. And when they came, the SpO2, the levels were 30. And the nasal pharyngeal airway was blocked, completely blocked. And the mother did not pay attention, And in spite, and we kept calling the child, the hospital, they did not bring the child back. When the child could not breathe, there was a problem, airway was completely blocked. Then they came to the hospital, and we had to admit the child to the hospital, because, and they said, moment we cleaned the nasal pharyngeal airway, the SpO2 level went up to 90, 95.
Dedication and that commitment is required to look after
Exactly.
these.
But we said, admit the child. We'll be from our side, we're going to pay for the child's NICU, admit the child, and do everything in our. But what the mother does she have that willpower? What she's facing? We don't even want to get into the family thing. But from our side, we said, save every child who needs the help, who's born with a cleft and having problems. So she said, can you imagine, child came, his respiratory levels were only 30. So So this is the reason for this awareness campaign. Wherever we find the child, we tell them,
As we see, even, the lady I scanned 3 days earlier, but the minute I told them, they sort of knew about it. It was not that they had heard about it at least. So they sort of knew, and so their awareness is increasing, and the people know that there is treatment for it, and the right approach needs to be taken.
Thank you so much, Doctor.
Thank you so much.
Ajay sir, you wanted to give some feedback?
Yeah, basically,
Thank you, Ajay sir.
thank you, Sitaji. It was very nice deliberation. I deliberately heard everything. So as I said, I get something new as always in every lecture from you. Okay, about the termination of the pregnancy after 20 weeks, it is not allowed for only cleft lip and cleft palate. It is not included in that list which government has given. From 21 to 24, there is a list given. For those purposes only in the anomalies we can terminate the pregnancy. The cleft lip is not included in that.
Okay.
So termination should be done before 20 weeks.
Okay.
That is a better option if it is associated with the other genetic problems or something else. If it is a isolated entity, then it is okay. We can, with the help of Smile Train and all the things, we can clear that after the birth. But if it is associated with the other genetic abnormalities, we can terminate. But for isolated cleft lip or cleft palate, we cannot terminate after 20 weeks. That is the provision in the modification of the.
Yeah, because isolated cleft
New
and palate
LGD
can be taken care of, because we've done so many surgeries, and we
Yes.
run this CleftCon program, and our patient, they are so successful, because God also gives them, one thing and makes up by giving them the other intelligence, or some are the other way. Some of them are such good performers, creators, and all that, So we have the big community in the cleft who's highly successful, Cleft is just on the something, this was a little different they are born with. They are absolutely mentally very active, agile. Sometimes they're very, very, we have someone who's running a serial program. He's from IIT Delhi, So sometimes, they just need the proper guidance, and they just need that confidence and motivation. And main thing is what we've seen in our program, unless and until you accept it, the family doesn't accept it, nothing will happen. When the family accepts it, there is a problem, and we will sort it out, and we'll look through it. We'll go through it together. Then it gets resolved. If you are in denial, it'll never get resolved.
And I as we said, that, we make it a point to not only counsel the couple, counsel the entire family, because it's
Exactly.
the family they have to go back to and live with them. And then when they don't get the right support, depression,
Correct.
everything, guilt, all sorts of sets in. And that becomes very difficult for them to cope with.
Yeah, sometimes for a nutrition program, you tell them, bring your mother-in-law along, because she is the head of the family, she will be, and if the mother is not comfortable, if she's under stress, she'll not be able to lactate, she'll not be able to feed the child, So the whole family counseling, you so rightly said, it's so important. Sometimes the husband would agree, but it's so important. The head of the family is convinced that it can be taken care of with the right care and right time.
Yeah, with the folic acid campaign, we have reduced certain amount of anomalies, basically. But again, we need premarital and pre-conception counseling, basically. So in Mr. Vice tenure, Sitaji, you can promote that.
Yeah.
Yeah,
a lot of
over to you.
counseling, a lot of work is required.
Yes, ma'am.
Yes.
Rajasi, for your comments as chairperson.
Now, as I had already told, Madam's lecture is always, it's a pleasure because most complicated topics she teaches us in a very lucid manner. And so also for today. Just from the ongoing discussion, I think that sonographic diagnosis is the mainstay. But for a obstetrician point of view, it also involves a lot of counseling and empathetic approach towards maybe continuation of pregnancy and the lactational problems which the ladies would face. So we should give equal importance to counseling the couple and the wife especially. And just as sir said, it's not a major anomaly. So if we diagnose it a little late, they are expected to carry the what
It's
we should
possibly
say
a blessing in
burden of a
disguise then.
burden is not a good word, but they have to carry that burden to the postnatal life, and that creates a lot of turmoil also for the lady. So we should be proactively counseling the couple, the patient, the in-laws. So I think these two should go hand in hand for this particular entity. A very nice lecture indeed. Thank you so much, ma'am.
Yeah, in
Thank
fact,
you,
one
Sita
of our
ma'am.
patient, she
Yes,
is
ma'am.
into one of the, she is a TV web series actress. And she said, when I stand in front of people, I said, I'm 5 feet 6 inches. Why do these 2 inches of my mouth define me? What about my 5 4 feet? But they don't define me. But people look only at my 2 inches and then why do they define me? And he said, yeah, it was so right, like they will not see the good thing. But I think, we got this habit, because on their face, people will first thing they will notice, they'll stare at you. And it happens to me also, like when I see someone that Cleft, because I can make out and I immediately turn back and I look, then I tell myself I should not be staring. But because I'm trying to find out, is he getting the right help or not? But because you all look back and the person who's got a Cleft gets more and more conscious about it. So we have to be a little mindful, like people who come across and talk to them and all that, why we're looking at it again, you're trying to help or whatever.
Yeah, Smile Train is doing the good work. But along with that, I must tell that Government of Maharashtra has started one mission from the school days. So school dropouts up to 18 years, they are brought back to the hospital for the surgeries free of cost, and it is paid by the Government of Maharashtra.
Okay.
It is a school health program.
Mhm.
So we are running this program since 12, 13 years, and it is giving good results.
Okay. So do you come across Cleft in those cases? No,
Yes,
children?
yes. We have operated 360 boys and girls are less in maybe I'm wrong in the statistical data, but the boys are more in cleft lip than the
Okay.
girls. Now,
Okay.
yeah, it is again a finding from our hospital. So 360 cases were operated in our hospital through this school health mission.
Okay. That's wonderful. We'll get in touch with you, Dr. Mane, separately. I will get in touch with you for this.
Yeah, sure, ma'am.
Yeah, because
Thank
we
you.
have in
Thank you.
Maharashtra, we have a campaign. We are training the A&M nurses also, because the midwives and
Yeah,
all that.
I have given one talk in Chhatrapati Sambhajinagar, that is Aurangabad, because Dr. Bembre is operating here from Smile Train family, and we have arranged one program for ASHA workers and the ANMs. What you told just now, 2,500 ASHA and ANMs were there for the program. It is a one-day full-fledged program. It was very nicely conducted.
Yeah. So we are planning to do a little training also, like we're doing it for you with you people, the awareness, like A&Ms and the midwives and all, because they also are delivering the children and all that. Even they are also the ones who come to know
Yeah,
about.
PST in sub-center level, they are doing the work.
Yeah. So we're planning to do something in Maharashtra. We're going to start with Maharashtra. If it works, we'll spread it to the other states also.
Done. We are with you.
So Maharashtra has always been our pet peeve. We try everything in Maharashtra. It works out.
We got so
Then we
many
take it
people.
to the
Na?
other
Rajesh is
states,
from Maharashtra, Monica is from Maharashtra, Supriya, Madan, myself, and Sita got
I'm
the training in
originally
Maharashtra.
Maharashtra, so
Bhaskar Bhai got the
I would
training in
like to be part
Maharashtra.
of it.
Yeah.
So basically, they also belong to Maharashtra.
So that's what, we like. This is the Amog's Foxy thing is we're working in Maharashtra. Then we spread, because we at the moment it's in-depth work we are doing in Maharashtra. So we're spreading to the other specialties also.
will be working for you. Yeah, no problem.
Yeah. Thank you so much, everyone.
But I'll have to leave. I think there's a patient.
Yeah.
Thank you,
Thank
Sita
you so
ma'am.
much,
Thank
everybody.
you,
Thank you
Rajyasree
so much,
ma'am. Thank you,
everybody.
Dr. Preeti, for chairing the session.
Thank you to
And
all of
Leela ma'am, I assure you that the next time we have a psychologist who will be discussing about the psychological issues and counseling. Because till now we have covered breastfeeding, ultrasound findings, medical legal aspects. Then we haven't touched about counseling. So the next session we will do on counseling of these patients, ma'am.
Wonderful.
Thank you, everyone. Ajay sir, thank you. Sujata ma'am, thank you. And thank you,
Thank you
Dr.
so much.
Varsha, Dr.
Thank you,
Madan
everyone.
sir, thank you.
Everybody.
Yeah, thank you to Dr. Ajay, Dr.
Thank you.
Sujata.
And thank you,
ma'am,
Hebzi.
Dr.
I
Varsha,
forgot your
ma'am.
name.
Thank you. Thank you.
Hebzi, thank you for the technical help and the timely flyers.
Thank you.
Thank you,
Thank you,
Smile Train,
Dr.
for the association. Yeah.
Thank you, Dr. Monica.
Bye.
Thank you, Dr. Sita.
Thank you.
We'll keep
Thank
in
you
touch.
so much, Monica.